All right, we're going to go ahead and get started here. Welcome, everyone. Thank you so much for the October webinar. It's a real pleasure to see some faces here that we haven't seen in a while, and some familiar faces as well. So welcome, and looking forward to a lively discussion. My name is Chris Fisco, the Vice Chair of Columbia University and Residency Program Director, and this is a real bi-campus effort between Columbia University and Weill Cornell Medicine and the Department of Rehabilitation to bring to you a webinar series on some updates in clinical care management. What we're hoping to do is target a broad-ranging audience that will hopefully include some folks in the community that are interested in this topic and folks that want to learn a little bit more. Today, we are talking on shoulder pain and what is rotator cuff syndrome. So joining us today, we have Dr. Vandana Sood and we have Dr. Caroline Lee. And I'm really pleased to introduce both to you. Dr. Sood is an assistant attending physiatrist at New York Presbyterian Hospital and assistant professor of clinical rehabilitation medicine at Weill Cornell Medicine in the Department of Rehabilitation. And Dr. Caroline Lee is an assistant attending physiatrist as well. She is at New York Presbyterian Brooklyn Methodist as well as at Cornell as an assistant professor of clinical rehabilitation medicine in the Department of Rehabilitation. Excited to hear this talk, and I'm going to go ahead and stop my screen share so I can let them share their screen and we can go ahead and get started.
Okay. Nice to meet you all. Dr. Sood and I will be kind of popping back and forth. We did a couple of slides each just to go over and kind of give you a comprehensive view between the two of us. So hopefully you guys will enjoy.
Great, let's get started. Good evening, everyone. My name is Vandana Sood, and I'm a sports medicine physician at Weill Cornell Medicine. It's great to be here discussing this very important and relevant topic, so thanks for joining us. Rotator cuff syndrome is a very common cause of shoulder pain. We see this daily in our clinics. So let's get started. So first off, we're going to start with a basic review of anatomy. And to do this, first we have to look at the structure of the bones. There's a number of different bones and joints that make up our shoulder complex. These help our shoulder move smoothly while also remaining stable. Here we can see the glenohumeral joint. We can see the AC joint or the acromioclavicular joint. And we also have the sternoclavicular joint and the scapulothoracic joint, which aren't pictured, but here we can see the basic bone structure of the shoulder. This is a complex joint. It's a ball and socket joint, and it has a number of different components to help it move. Next up, we're going to be talking about shoulder function. And we can see that the shoulder has many different planes of movement. We are able to flex our arm forward ahead of us. We're able to extend it back behind us. We're able to do something called adduction and abduction, which is moving our arm closer or further away from our body. And we're able to also rotate our arm both internally and externally. In order to be able to move in all these different planes, we have a number of different muscles which are listed here that are activated to help support our shoulder. Our shoulder is very, very mobile. And in order to do this, it's actually the most mobile joint in our body. And in order to do that, we need all these muscles to provide support and to add a degree of stability. Because of this, it's also more prone to injury. And that's one of the reasons why rotator cuff syndrome is something that comes up so frequently. Next up, we'll be moving on to our next slide. And this brings up another really important topic, which is motion in the scapula. So classically, we think of the shoulder joint as the ball and socket joint of the glenohumeral joint, and that when you lift your arm, that's the joint that needs to move up. But you wouldn't be able to move your arm in all directions if the bones of the back of the shoulder, the scapular part of your shoulder, wasn't moving smoothly. So in order to move our shoulder fully in each direction, we need our scapula movement to be smooth. We need it to properly move out of place and support the shoulder as it moves in different directions. And this is definitely something that it's important to evaluate whenever you are evaluating someone's shoulder movement, is to really understand how all the bones of the shoulder are moving. In addition to, so we have the bone structures of our shoulder, and then because the shoulder is so mobile, we need to have a lot of structures that help stabilize the shoulder. And these stabilizers help the shoulder from popping out of place or from basically allowing for injury as we move in different directions. So first up, we're going to talk about static stabilizers. So there's a couple different types of these. We have a number of different ligaments around the shoulder. We have ligaments that connect the various bones in different directions, and these all add stability as the shoulder moves. We also have the capsule, which you can see over here, and this is sort of like an overall covering that adds an extra layer of stability around the outside of the shoulder. And in addition, which we don't see pictured here, we have our labrum tissue, which is a tissue that helps deepen the cup that the head of the shoulder, the head of the glenohumeral joint sit in, and that also adds a degree of stability. Next up, we have our dynamic stabilizers. So these are a different type of stabilizing tissue. These are muscles and tendons. So these ones act by stabilizing, but they're also really important for movement. So the ones that we think of most commonly are rotator cuff muscles, the rotator cuff muscles and tendons. And these are the ones that are pictured here, and there's 4 of those. And then in addition to that, we have all these other supporting muscles of the shoulder. And these are the muscles that help stabilize the scapula and stabilize the rest of the arm to make sure that movement in this region is smooth. So today we're specifically focusing on the rotator cuff. So the rotator cuff, to review, is a collection of 4 different muscles and tendons, and you can see the 4 of them listed here. And these muscles and tendons attach on the front, the top, and the back side of the glenohumeral joint, and they really help. They help the joint rotate, they help stabilize, and they help provide muscular balance. Because of where they're positioned between the various bones, and because of how integral they are and how frequently they're used in shoulder range of motion, they're prone to injury. And we know that with age, with overuse, with a particular kind of injury, all of these tendons, some more so than others, are prone to inflammation or potentially even tears in the tendons. When you have inflammation or tears, this can present with a patient who's having pain or dysfunction or weakness around their shoulder. So the more common causes of rotator cuff related pain are rotator cuff impingement and tendinopathy. And these are actually the most common causes of shoulder pain in general in the population. From here, I'm going to turn it over to Dr. Lee, who's going to go into more detail about this.
Great. Thank you, Dr. Sood. You did make a brief mention of impingement versus tendinopathies and tears. So we thought we'd probably mention it as a good basis of things, because impingement and tendinopathy often present similarly clinically. You'll have pain with overhead movement. You'll have pain with trying to activate some of the muscles of the rotator cuff, but oftentimes it's because of the compressive forces of the surrounding structures. So the shoulder joint, as we know, is very complex. You have lots of bones, supporting ligaments, and joints that can cause other problems in the joint itself. The bones in particular that can come in and cause some compressive force are the acromion, which kind of slides over the top of the shoulder and sits on top of the humeral head, or the coracoid process, which is a little bit further down and closer to right where you feel your pec coming into your shoulder. Some of the supporting ligaments that were on the slides from before, the acromioclavicular, acromiocoracoid, those ligaments that normally provide some support for the shoulder, if they do get inflamed, they can cause what we call an impingement syndrome because they're a little bit more voluminous than normal and will restrict your range of motion. Your AC joint, your acromioclavicular joint, will also cause a little bit of impingement from the top of your shoulder blade. And that's that bone where the clavicle comes to meet your shoulder blade from the top. And sometimes it can develop a little bit of a hook, where you can see on the slide to the right, where it gives a little bit of pinching in the area where your supraspinatus tendon is supposed to be trying to move back and forth nice and smoothly. Like we mentioned, clinical presentation can be similar to rotator cuff tears. And sometimes if you do have a little bit of instability, the surrounding structures try to pitch in, try to add some stability, and they get inflamed, then cause this impingement syndrome. So overall, the demographics for shoulder issues, they account for about 4.5 million physician visits a year, or 11.2 cases per 1,000 patients. How does that kind of refer to almost everybody in the general population? It's about 2 to 3% in a normal population. That includes the ages from 5 to 85 to 105. This problem in particular is more common in older adults, and the rates increase with age. So in the under 20 age group, the rate is only about 9.2%. But once we get to 80 and up, about 67% of patients can have a rotator cuff tear or rotator cuff impingement. Signs and symptoms of those occur very frequently in an older population. This is also very common in working populations. It's actually the second most common work-related injury. There was a study done out of Europe that showed that in the course of their lifetime, somebody who does a lot of labor and a lot of extra work, well, 54% of them will actually experience shoulder pain, which is a pretty notable number. The only other injury that's higher is back pain. And for those patients, it's about 60%. So a difference of 6% in your lifetime for work is pretty significant. There are many risk factors that go into developing rotator cuff tears and rotator cuff syndromes. Some of them are modifiable, meaning that we could try to change some things, how we work, positioning, activities. Some of them are non-modifiable, meaning that we can't really change them. And we try to do the best that we can to make sure that you guys can stay active and mobile. Modifiable risk factors include repetitive overhead activity via either sports or work. And I've listed a couple of sports down there. Swimming, tennis, throwing sports in particular, golf, weightlifting, volleyball, and gymnastics. Basically anything that kind of gives you that overhead movement where you're trying to swing through with any sort of force can be considered a repetitive overhead activity that would predispose you towards a rotator cuff injury. If you did have a dislocation at a young age or recurrent dislocation, it does imply some instability, and instability in the shoulder will put stress on additional structures in the shoulder, which will predispose towards tears. Smoking and high cholesterol will also predispose towards tears, and that's more related to kind of chronic vascular changes, as the tendons in that area don't have great blood supply. And so sometimes you can cause other changes in that area related to your entire body status. Non-modifiable risk factors are age, genetic or familial disposition. So if you've had other people in your family who do have rotator cuff issues, they might have different anatomy or morphology that have changed the way their shoulder moves and might predispose you towards a rotator cuff issue. I did put a diagram down here on the bottom right where it says type 1, type 2, and type 3. In particular, that's pointing out the hook of that acromion or the shoulder blade where it comes up to meet your clavicle. Sometimes it could have a little bit more of a hook to it. Sometimes it could be more flat, and that could predispose you towards rotator cuff injuries as well. So as far as clinical presentation goes, a lot of it, like we mentioned before, will be shoulder pain with overhead activities. There'll also be commonly pain with activities of daily living, such as brushing your hair, putting on clothes. A lot of patients will complain of sleeping on a particular side or trying to throw an object, even just kind of throwing your phone onto a bed might hurt. They'll also report some weakness. If you're an athlete, you would probably note a decline in performance, maybe less speed, less accuracy, or endurance. And back to Dr. Sood for some physical exam pearls.
Okay, so in addition to the clinical history, which is what the patients tell us when they come into the office, which is such a big part of making the right diagnosis, another really important piece of the puzzle is the physical exam. So for anyone with shoulder pain, it's really important to do a comprehensive exam. We start by looking at range of motion. We talked before about all the different planes that the shoulder can move in. We want to see if the patient is noticing any restriction in any particular direction. We also look at the back of the shoulder, again, looking at that scapula and making sure that it's moving smoothly and that we don't see anything that looks asymmetric compared to the opposite side. We check the muscle strength around the shoulder to make sure that the muscles are firing and appropriately able to support the shoulder. And then we do a number of special tests, which are essentially specific positions and maneuvers that we do that can isolate the specific muscles and tendons of the rotator cuff, as well as the other supporting structures of the shoulder, so that we can help identify what the painful structure may be. Sometimes there may be more than one, but it can be helpful to kind of narrow down what's driving the patient's symptoms. In addition to all this, it's always also really important to examine the areas around the shoulder. So when you're doing a shoulder exam, it's super, super important to also think about, could this be neck pain that's radiating down to the shoulder? So we also tend to do a pretty comprehensive exam of the joint nearby. So the neck exam is super important when examining the shoulder. So in addition to the physical exam, we often use diagnostic tools to give us a little bit more information. So most commonly for shoulder pain, we have 3 imaging modalities that we tend to use. First and foremost is x-rays. These are probably the most ubiquitous and the easiest to obtain typically. And these can show us anatomical differences, and they're really good for showing us arthritis or bone injuries or potentially calcification that's developed in the shoulder. Another really exciting and helpful imaging modality is ultrasound. And sometimes we're able to even do this in the office during the visit. This can help us look at tendons, and sometimes we can pick up if there's any tearing or inflammation in the tendon, if there's calcifications, if the tendon looks irregular in any way. And sometimes if we can use the ultrasound even in a more dynamic fashion and can really see what's happening in real time when you're doing a movement that's painful and can potentially pick up impingement. And then we have the MRI, which is probably the most comprehensive imaging study of the shoulder. And this is really a good option if you're interested in looking at the deeper structures of the shoulder. If you're looking for, say, a partial tear that perhaps maybe wouldn't necessarily show up on the ultrasound, or if you're looking for something like a labral injury, or if these other imaging modalities didn't provide you with enough information, the MRI can sometimes add a little bit more context. Here we have some examples of ultrasound images of the shoulder. Here we can see how the ultrasound does such a great job of picking up the borders with bone, muscles and tendons in the shoulder. And then here are some examples of some pathology that you can pick up using an ultrasound. So here we see a full thickness tear of the supraspinatus tendon in the shoulder. And this is very clearly visualized on ultrasound imaging. In addition to that, on the next picture over here, we see actually an example of calcium buildup within the tendon. And the ultrasound does a great job in this instance of kind of localizing the area of the calcification and kind of helping us to kind of quickly confirm the diagnosis. And then, like we mentioned, sometimes you need an MRI. And here are some MRI imaging studies, some pictures from some MRI imaging studies. And over here, we can see some bursitis in the shoulder. And this MRI is doing a great job of kind of highlighting the pain and the inflammation in the bursa around the shoulder that may be driving some of this patient's symptoms. Here in the middle picture, we see an example of tendinopathy or irregular changes in the tendon, where we can see that the tendon clearly doesn't look normal and homogeneous the whole way through. And then in the last picture on the side, we can see a full thickness tear. We can see very clearly that the tendon is torn. And we can see that gap over there. So the MRI can be a very helpful additional piece of information for the right patient.
So what do we do for treatment? So our first line of treatment and first line of conservative management is usually physical therapy. This works very well for partial tears, and there is some benefit in chronic full thickness tears. Physical therapy is typically split into 3 different phases for the rotator cuff in particular. The first one being mobility, because you want to restore the range of motion. To do that, we always compare to the other shoulder, because we assume that your other shoulder hopefully is normal. And then from there, once they say, oh, you're within 5 to 10 degrees of your range of motion, they'll hopefully move on to strengthening your shoulder. So a lot of times they start off with resistance exercises, and they're always trying to perform them below the level of the shoulder height. And this is protective to your shoulder. This also means that you can utilize some of the other stabilizers in your shoulder, not just the rotator cuff, but the scapular stabilizers, to overall make your shoulder stronger, more stable, and hopefully more functional. That third phase of physical therapy focuses on function, so exercises that stimulate joint reactivation. Sometimes they might do what we would call plyometric exercises, where they're a little bit more accelerated, they have a little bit more power to them. Those are more for patients who are looking to get back to certain sports. And even if it's just some small movements, being able to kind of like, pull open a door, that kind of thing, the focus on those as part of your activities of daily living and function. Overall, physical therapy has been known to improve range of motion, improve pain, and improve tendon function and tensile strength. Another potential treatment for rotator cuff injuries is injections. You could do steroid injections, which give you a short-term benefit in controlling pain. Steroids, unfortunately, do cause some tendon degeneration with time. So if you're using it to treat for long-term, it's not really recommended. There are a few studies that say how many that you're actually supposed to do, 1 versus 2 versus more than that. It's generally not recommended to do more than 4. It's recommended to do 2 or less if it's a partial tear. If it's a full thickness tear and you're using this because for some reason you can't get an operative repair, then it's up to the discretion of the provider. Those would be included in other medical factors that are poor health, severe, or chronic rotator cuff tears, which might not be a candidate for surgery or have a good outcome from that. More recently, we do have some data on platelet-rich plasma. There are a couple of studies that are a little bit split on whether or not platelet-rich plasma is good for rotator cuff tear, partial or full thickness. There was a recent paper that was published about a month ago that did note that some use with platelet-rich plasma or bone marrow aspirate concentrate can improve long-term surgical outcomes by preventing re-tears. But it was a very small study, and we're looking for follow-up studies before we can give more solid recommendations to our general patient population. I did put the slide down here just over in the bottom right-hand corner to just briefly explain what platelet-rich plasma is. It's a sample of your own blood that we spin down to isolate the platelets. Platelets are historically known for healing or clotting blood, giving you that nice little scab when you have a cut on your arm. But it also recruits some growth factors, which is the idea behind using a platelet-rich plasma to try to heal tendinopathies, tendon tears, that kind of thing. The last option in our toolkit for treatment is surgical repair. Unfortunately, some patients, when they do have acute full thickness tear or previous partial tears with new sudden loss of motion, sudden loss of range of motion or function, we might recommend them for a surgical repair. The other patients that might also qualify for this are patients who've tried conservative management and they're really looking for a little bit more. Operative repair does help to stabilize the shoulder, so will prevent injury of the other structures in the area because there's a lot going on in that shoulder. Surgery does tend to be good for pain control, but you may lose some range of motion. Understandably, the surgery has to kind of tighten things down, and when they tighten things down, you will lose that range of motion. As you can see kind of in slides A and B, or in the picture A and B down in the bottom left, there are several different ways to do it, and it's based on your surgeon's preference. And then, so sometimes you can have repeat episodes of instability with need for repair that might predispose towards a shoulder replacement later on in life. And this might be a good reason to get it repaired early rather than later, but also depends on the patient, depends on the case, depends on what you've tried before. Now to the fun stuff, the injury prevention. So because we remember from that demographic slide that about 67% of patients over the age of 80 will develop some sort of rotator cuff pathology, injury prevention is always big on our mind. A lot of the exercises these days actually target different muscles. Some of them are stretches, some of them are just trying to strengthen up the scapular stabilizers in that area. I highlighted 4 lovely exercises here that you can do at home. The first one on the top left is called the sleeper stretch. It's basically going to stretch the outer and upper part of the backside of your shoulder, and it targets two of the muscles of the rotator cuff itself, which usually help for the very specific motion of trying to come up and out, but with your arm. The one down below that on the bottom left side is a very simple activity called scapular setting, and it targets two accessory muscles, your trapezius and your serratus anterior, where you're kind of laying prone and you're squeezing your shoulder blades back. That squeeze back will allow you to strengthen your upper back at your shoulder blades so that you could kind of stabilize that shoulder from the posterior aspect. In the top right, we have an exercise where the patient looks like they're laying down on a table. You could also do this laying down on the bed or on your couch. And you basically have either a small weight or even just a can of soup. And you're bringing it 90 degrees out from your shoulder. So just try to keep your arm in line with your shoulder, not going above, not going below. And just bringing it straight out and squeezing that shoulder blade down and in to try to activate the muscles of trapezius, infraspinatus, teres minor, and posterior deltoid, so that it can strengthen the back of your shoulder and the upper back as well. The last exercise that I highlighted down at the bottom right is just internal and external rotation. So oftentimes when we do have a rotator cuff injury, we lose a little bit of that range of motion, and we don't realize it until we try to, touch our head, scratch the back of our head, or do our hair. So maintaining the range of motion is also very, very helpful. Doing this exercise kind of laying down with your arm straight up in the air, your elbow way out to the side, just right at the level of your shoulder, and rotating up, down to the table, back down to the table, will target the anterior and the posterior deltoid, the subscapularis, infraspinatus, teres minor, and latissimus. So a lot of different muscles that go into movement of your shoulder, but it'll also help stabilize that shoulder. Again, it'll strengthen the front and the back of your shoulder, your chest, and your upper back, so that we could do a lot of work into your shoulder area. For injury prevention for throwing athletes, there is actually a protocol called the Throwers 10 or Advanced Throwers 10. These are a series of different exercises, and they actually have a kind of like a booklet of it that you can find either with a physical therapist or you can find it online, where they're concentrating on several different kinds of movements, but they're working on single leg balance, trunk stability, abdominal strength, and this would be more of exercise that you can do kind of after you've done the more simple ones to strengthen up the smaller muscles of the rotator cuff and strengthen up that shoulder in general. If you are looking to do something like this because you are a throwing athlete, the first thing would actually to also be to limit your throwing volume if possible. We found that in adolescent pitchers as well as older pitchers, limiting the throwing volume does prevent additional shoulder injuries, as well as keeping just general track of it. So, pitches are one thing, but throwing a ball is another. So those numbers in conjunction often will help us limit that throwing volume. The other thing that might also be helpful if you are a throwing athlete or thinking about getting into throwing sports would be a biomechanical evaluation. A lot of times there are throwing coaches, either at physical therapy or associated through different sports clubs, that will be able to evaluate your form and see if you do need a little bit more work with this single leg balance, trunk stability, abdominal strength. So that's kind of most of it. Do we have questions, I guess?
Thank you so much, Dr. Lee, Dr. Sood. Really appreciate that overview of shoulder pathology, workup, and treatment paradigms, including some advanced stuff in throwers. I'd be happy to entertain questions. Anyone that would like to ask a question, you can go ahead and use the chat. Certainly, if you don't have access to the chat, you can use the unmute feature as well. But I'm going to go ahead and kick us off with a question. Help me understand in your clinical practice when you escalate something from physical therapy to an injection. When do you decide that an injection is needed? How do you know?
So I can answer that. So that's something that actually comes up very frequently. And usually an injection is something to consider when a patient is having trouble performing the exercises or participating in the physical therapy. So often I'll have a patient start with physical therapy and maybe they do a few sessions and either they or their therapist feel like their progress is potentially a little bit limited by a significant amount of pain and inflammation, and maybe they aren't able to tolerate some of the exercises. So that's a good time for a patient to maybe circle back and to consider an injection, which sometimes can help kickstart the process and kind of allow them to make more progress.
I definitely concur with Dr. Sood. Sometimes if the patient seems to be in too much pain, even before they're starting their physical therapy, I'll ask them, I'll kind of gauge their response if maybe an injection before they do the physical therapy might help as well, just so that they're able to participate fully, even before having to kind of circle back. It really does depend on the patient though.
Thank you. So when we have a question coming from the chat here. There is a mention of weightlifting. So was it the sport of weightlifting? So I guess sportive weightlifting or lifting weights. So what exactly was the citation there? I don't actually know if I recall exactly when that was mentioned, but maybe.
So it's so it's over in the demographic side. So it specifically mentions Olympic lifting, because when you're doing that snatch and clean motion where you're coming up all the way above your head to bring the barbell above your head, it does allow for a little bit more rotation on your shoulder and puts a lot of stress because the weight has to come down onto extended arms into a shoulder joint that does need to have all the rest of the shoulder stabilizers firing at the same time. There is some concerns when you're doing other exercises, even just bench press, even basically an overhead with a dumbbell, which will cause and predispose towards rotator cuff injuries. And what we can mention is kind of like when we did in the treatment exercises and the physical therapy program, is try to limit your shoulder from going above 90 degrees when you're doing these exercises, unless you're very, very comfortable doing, Olympic lifting, powerlifting, that kind of stuff to get that weight above your head.
Yeah, because this is where I changed my thought with everything. And you had a picture of a woman holding, I guess it was a plate over her head. And I thought the form was really good. Because now I'm saying, like, I just want to get the muscle stronger. And I started doing a lot more overhead presses with people. And as long as the form is okay, they've been doing well. And as Dr. Sood pointed out, like in the overhead movement, the scapula does rotate out of the way. So you're not really impinging the shoulder. So yeah, I'm not a huge fan of the Olympic weightlifting, but I do like the overhead press, which sounds antithetical to what we're kind of going over. But it has been working.
Really, it's if you have patients who are able to do it with good form, then they can progress. Obviously, a lot of our patients who do have rotator cuff injuries will be on the older population, so they might not be doing an overhead press. But if they're starting off slow and going up very slowly with the weights and not, being like the 20, 30-year-olds and jumping straight to doing like the barbell with like 120 pounds on it, I think they'll be okay.
Nice. Thank you.
Great, thank you. And really important to the points that are being made here is full range of motion before progressing to strengthening, and then strengthening can progress on from there, and all within good form, good function. Help me and maybe some of our participants understand the role, since we're talking about some treatments here, let's talk about some of the more basic treatments. Ice, heat, rest, and anti-inflammatory medications. And, I feel like we touched on that, but specifically, there's some controversy on anti-inflammatory medications, NSAIDs. How long do you use them? When do you use them? Do you opt for ice ever, or more aggressive icing? For that matter, some of the devices that are available where you can do whole shoulder icing and all this. Do you do any of that, or ever alternate with heat and that? So maybe you can comment on that.
Yeah,
So
absolutely.
go ahead.
Oh, Carolyn, you can go ahead.
So generally, when I talk with patients about ice and heat, I usually talk about it in the context of trying to do some light stretching or some exercises. And so, as you find at most physical therapy places as well, using a heat pack to kind of start to warm up that shoulder, get it a little bit looser so you're able to start doing those stretches without having a lot of pain, and getting that little extra range of motion out of that with the heat is usually recommended. I do tell patients afterwards to kind of cool down that shoulder joint with the ice after they're done with their exercises for about 10 minutes or so. Much longer than 20 minutes shows that we have something called reactive vasodilation, which increases the blood flow and inflammation into the area, which is not necessarily something we want. So kind of doing heat to start, do some of your exercises, stretching, and then cool it down with ice for about 10 to 15 minutes is usually the protocol I discuss with my patients.
Dr. Sue, did you have something to add to that?
I would say that I do think that we also do frequently end up using anti-inflammatory medications. But I do think that the role for those is for a patient who has acute shoulder pain that's currently worse than it's been, either worse than it's been in a while or started recently. And it's usually something that I prescribe for a pretty short duration. So usually about a week, maybe 10 days. And the goal is to kind of quickly help get the inflammation under control if we're thinking that this is something that happened recently and that there is some inflammation to wash away. Someone who's had chronic pain in the shoulder for years and years is probably not somebody who would necessarily get as much relief from the medication. So I definitely think there's a role for medication, but it really depends on how severe the patient's pain is, how long it's been around. And that's definitely something, it's always something to consider.
Indications for X-ray?
I don't order X-ray for every patient at the first visit. It varies. Sometimes it depends on, if the diagnosis is completely clear and you're very positive that this is what it sounds like, and this is a rotator cuff issue, then, X-rays may not give you very much information. But for other patients, sometimes shoulder pain is multifactorial. And for some patients, the pain is severe enough that you do want to get some sort of imaging. For example, someone who has really severe shoulder pain, either an X-ray or an ultrasound might be able to pick up a calcific deposit in the shoulder. So I definitely think there is sometimes a role for imaging on the first visit, but for the average patient who comes in with an acute flare of shoulder pain that seems like a rotator cuff related issue, I don't think imaging is necessarily needed on the first visit.
All right, let's talk on PRP. There's a lot of questions coming in here on PRP. I know not everyone can see the messages. Some of them are on my list only. I'm going to read one off. Dr. Sudenly, in your experience, have you found patients who received PRP injection have been able to avoid surgical intervention? Or have you found that PRP intervention plus conservative therapy helps to avoid surgical intervention? So PRP alone or PRP with some directed therapeutic treatment, does that help to avoid surgery?
I found that really depends on the target of PRP, as well as the pathology that's affecting the shoulder itself. If you have a full thickness tear, it is recommended to get a surgery more quickly because, especially an acute tear, because those tendon surfaces can retract. And because of that, you'll lose a little bit more function than you would with like a partial tear. PRP would be more recommended when there is kind of more of a basement kind of area where we can try to start to fill in the gaps with the PRP, because it does lay down some fibrous tissue. That fibrous tissue is short-lived, however, and even when we're using it for, say, a knee joint and it does fill in some cartilage, it usually only lasts up to 1 to 2 years in our animal models. And therefore, it can be a solution to stave off a little bit to be able to strengthen the other structures around the shoulder, to decrease some pain, to increase some function. But for right now, the research is not showing that it's great for long-term outcomes. I did mention in the slide before that they have been used for gaining more positive surgical outcomes. And then in that recent study, they had a 3-year follow-up after doing rotator cuff repair with the addition of PRP. And it showed that the patients who did receive the PRP did have a lower incidence, a statistically significant lower incidence of re-tears of that rotator cuff.
There was a question that came in on when to get ultrasound. Do you get ultrasound before X-ray, after X-ray? I think I could probably speak for all of us to say that those are complementary pieces of information, and oftentimes we'll get ultrasound with X-ray. But this next point on the scapulohumeral dysrhythmia, how does that affect the shoulder and the rotator cuff? Can you get into that a little bit? And it's a complex topic to explain over Zoom, I will say, but let's leave it to you. Can you
Agreed.
give us a few more
Yes,
thoughts?
so it is a very complicated, the way that the shoulder, the movement of the shoulder is probably the most complicated movement pattern in any of the joints in our body. But essentially, if the scapula doesn't appropriately rotate, so as you lift your arm and the glenohumeral joint starts to rotate, the scapula needs to rotate in tandem to essentially move out of the way and support the shoulder. And if that isn't happening in a smooth and controlled fashion, you can end up primarily with impingement, which is where the scapula isn't able to fully move out of the way. Your humerus and glenohumeral joint are trying to lift, and essentially what gets squeezed? Well, some of the tendons can get pinched, and you can get impingement syndrome in the shoulder, which is classically the supraspinatus that gets pinched between the bones. So that's definitely one of many considerations, but that's definitely like a common thing that we see. You can also get the scapula, there's a number of different muscles supporting it. And there's a number of patients who get upper back pain along the borders of the scapula and some inflammation or irritation along where the muscles and bones move. So ideally, if the muscles that support the back of the shoulder, the rhomboids, the lower trapezius, the deltoids, if those muscles are appropriately firing and helping the scapula move the way it should, movement is going to be more smooth, less irritating, less inflammation, less pinching, and hopefully less symptoms for the patient.
Well, that was pretty great answer for Zoom. So I think I've got a pretty good picture in my head about what that might look like. And Dr. Lee, maybe you can help me understand this. We talked about a lot on rotator cuff. We talked a little bit about some of the specific tendons. But the other big structure in the shoulder joint is the articulation of the joint itself. So the glenohumeral joint. Now, this being on rotator cuff, we didn't focus on that very much, but help me understand what role osteoarthritis has with the rotator cuff. Do people with osteoarthritis, are they more prone to getting rotator cuff issues? Do they also get rotator cuff issues? How does that look?
So, like I mentioned before, a lot of the anatomical variants in the glenohumeral joint, as well as in the acromioclavicular joint, can predispose towards other issues. For example, if we examine that the glenohumeral joint is supposed to be a ball and cup, albeit a very shallow one, if the cup is too deep, then the humeral head has a hard time rotating up and over, causing some inflammation in the other structures, some more stress in the other muscles that are supporting the shoulder itself. If there becomes, or if arthritis starts to develop in the shoulder because of some instability, or if the cup is too deep, then the other structures around it, they're also being pulled in a very strange way. They're being pinched as opposed to being stretched with the shallow cup versus a deep cup. And then the instability of the shoulder developing arthritis will also make osteophytes, so little bony spurs in the area that could also chew up and cause issues. Sorry, my screen just shifted. Cause issues and inflammation into the rotator cuff tendons and the supporting structures of the shoulder. That instability will, sorry, there's a lot of motion going on the screen. That instability can add into other inflammation in the other structures of the rotator cuff and cause rotator cuff inflammation, leading to impingement, possibly leading to tears, based on how much instability there actually is. The understanding is that if there's a lot more instability, you're going to predispose towards a tear versus just having impingement syndrome, where the structures just get pinched every once in a while, and then obviously cause a lot more pathology and a lot more pain. Unfortunately, that's longer lasting.
Well, I think that's all the questions that we had for our viewing audience here, and for myself. I'm double checking the chat here, and really appreciate the two of you for joining us today for this really important topic of rotator cuff and rotator cuff syndrome and shoulder pain. There's obviously a lot more to know about the shoulder, and I'm hoping in future sessions we'll be able to dive more deeply. I'd like everyone to hold the date of November 5th. Sorry, excuse me, 5 p.m. on November 8th. Get it right. On golf injury and prevention. That should be interesting. I'm sure we'll have a lot to talk about with both upper and lower limb. I think Dr. Lee is coming back for that. Is that right, Dr. Lee?
Yep.
Okay, great. So we'll keep hearing more about it, and really appreciate the viewing audience for joining us today, and keep tuning in. Thanks so much.